Welcome to the third presentation of ACCC's three-part knowledge series on CLL treatment strategies, sequencing, and care optimization. Today, we'll focus on care optimization. My name is Adam Kittai, and I'm an associate professor of medicine and CLL clinical research leader at the Icahn School of Medicine at Mount Sinai Hospital in New York, New York. I serve on the advisory committee for this program along with Jennifer Woyach, professor of medicine, leukemia, and hematologic malignancies program co-leader at Ohio State University in Columbus, Ohio. I want to go over some key strategies to alleviate adverse events. For one, if the adverse event is not life-threatening, a dose hold is always an option. Remember that if someone has good disease control on a continuous BTK inhibitor and they have an adverse event that you think is due to the BTK inhibitor, sometimes you can stop that drug for years before patients progress with their disease. One thing I like to remind my patients is that not all adverse events are due to the targeted therapy. So a dose hold is a nice option because if the adverse event gets worse, then you know that it's not related to the targeted therapy you're using. However, if it gets better, then yeah, maybe it's due to the targeted therapy. If we think it's due to the targeted therapy, we can consider restarting at a lower dose, and then you could try ramping up to the normal dose in the future. Currently, because we know that second-generation BTK inhibitors have an improved safety profile to ibrutinib, if somebody has a toxicity to ibrutinib, I am quick to switching to a second-generation BTK inhibitor. Additionally, if someone has a toxicity on acalabrutinib or zanubrutinib, I also switch to either acalabrutinib or zanubrutinib, as we have new data that supports this approach, where, interestingly enough, side effects are not ubiquitous across the BTK inhibitors, and when you switch, sometimes the side effects can be alleviated. If the AE is due to the underlying CLL, specifically if the CLL is involving the bone marrow and you have cytopenias due to the CLL, consider continuing the therapy and give supportive care only. So for instance, if they have neutropenia, I will also give them growth factor support as opposed to stopping the targeted therapy. We'll go over this a little bit more when we talk about the venetoclax treatment on a future slide. But I just want to encourage patients and providers to continue the targeted therapy if the CLL is involving the marrow and continuing either and giving either GCSF support or give a platelet stimulating agent as well. So this was a really interesting study that looked at patients who had ibrutinib dose reductions versus those who did not have dose reductions and showed that patients who had dose reductions had an improvement of time to next treatment compared to those who did not have dose reductions. So I think this tells us a couple of things. I think that this tells us that patients who had dose reductions were able to stay on the ibrutinib. That's probably a reason why there was a longer time to next treatment on those patients. But it also tells us that maybe that we've been treating with a too high dose of ibrutinib from the start, and that we can get away with equal outcomes if we're able to do a dose reduction. That being said, for patients who have side effects on ibrutinib, given that we have two randomized phase 3 studies that showed improvement of side effects with the second-generation BTK inhibitors, is that I typically will switch to a second-generation BTK inhibitor pretty quickly if someone has a toxicity on ibrutinib. So here's a good example of that. So this is data from the Elevate-RR study that compared ibrutinib to acalabrutinib. And what they showed was that there was a reduction in the rate of atrial fibrillation for patients treated with acalabrutinib. So let me walk you through this slide real quick. The top two dotted lines are patients with a prior history of coronary artery disease or cardiac dysfunction or atrial fibrillation, showing that these patients did have a higher rate of atrial fibrillation than those who did not. But as you see on the bottom two lines, patients without a prior history really did well on acalabrutinib and had a significant improvement in atrial fibrillation rates compared to ibrutinib. So how do I monitor patients when I start them on BTK inhibitors? For startup, I usually see my patients 2 weeks after starting, a month later, and then every 3 months thereafter. Most patients who get started on BTK inhibitors exhibit symptoms sometime in the first year with improvement of the symptoms as the years go on. So I usually start by watching them a little bit closer at the beginning of therapy. This startup timeline also highlights that patients with BTK inhibitors really have a nice startup where they don't have to be monitored so closely when initiating therapies. At every visit, I remind patients of the main adverse events to watch out for. These include joint pain, hypertension, easy bruising and bleeding, and atrial fibrillation. I also remind them at each visit that they need to hold the BTK inhibitors prior and after procedures, and to please call me when they have procedures so that way I can discuss with them how long to hold the BTK inhibitors before and afterwards. Typically, we hold the BTK inhibitors 3 to 7 days before the procedure and 3 to 7 days after procedure. Of course, if someone has an emergency procedure, I just hold the BTK inhibitor afterwards without thinking about what's been done before. In terms of the cardiac comorbidity, which I know is everyone's biggest concern for BTK inhibitors, I usually handle it in this manner. And I like to remind my patients that once again, that the risk of atrial fibrillation with the second generation BTK inhibitors is quite low in the 1 to 4% range. And so really to self-monitor them as they're getting treated with therapy. So for patients who have cardiovascular comorbidity at the start of therapy, I'll think about getting an EKG every 3 months when I see them. If they don't have cardiovascular comorbidity, then I don't do this. But this really helps us monitor whether or not someone might develop atrial fibrillation that they're not feeling, which might increase their risk for stroke. And there's been good studies that show that patients who have baseline cardiovascular risk have a higher risk of developing atrial fibrillation. I like this slide because it helps us remember the main cardiac risks for patients being treated with BTK inhibitors. The main two are hypertension and atrial fibrillation. We can see ventricular arrhythmias, but these risks are quite small, and we can see heart failure, but this is really related to undiagnosed or untreated hypertension that might occur over time. And I really do lean on my cardiology colleagues whenever someone may have cardiac risk and I plan on putting them on a BTK inhibitor, I might send them to cardiology a couple of months before treatment is planned to help optimize their heart function prior to going on therapy. What's nice about patients with CLL is that we often don't treat them when they get first diagnosed, and oftentimes we have the luxury of watching them over time, making sure that their cardiac disease or their cardiac comorbidity is lessened the best we can, especially, as I said, if we think we're going to be putting them on a BTK inhibitor in the near future. In terms of venetoclax, the most dreaded side effect is tumor lysis syndrome. So how I like to explain this to patients is that our drug works so well that the cells break apart and put a lot of stress on the kidneys, which can overall turn into tumor lysis syndrome, potentially leading to hospitalization and obviously death. And so I do take this very seriously. A couple of things that I do to alleviate the risk of tumor lysis syndrome is that everybody gets allopurinol for the entire length of their venetoclax treatment. I think this might be a little bit overboard. To be honest, I'm not sure if this is shared as an opinion amongst my CLL colleagues, but definitely have them on allopurinol for at least the first 3 months of therapy. I also take this tumor burden risk very seriously. So patients who have low tumor burden, lymph nodes less than 5 centimeters, and ALC less than 25, we can get away with treating their venetoclax ramp up as an outpatient and do the pre-dose and post-dose testing as described and encourage oral hydration. If they have medium risk, defined as a lymph node 5 to 10 centimeters or an ALC greater than 25, we also can usually get away with treating them as an outpatient, but if they have kidney dysfunction, I oftentimes will admit them to the hospital. Lastly, if they have high risk, any lymph node greater than 10 centimeters or an ALC greater than 25 and a lymph node greater than 5 centimeters, I do hospitalize these patients for the first and second ramp up. I think this is important because tumor lysis syndrome can be avoided with proper care, and that's why it's essential that I monitor these patients per the package insert. So patients being treated on obinutuzumab and then venetoclax, we give the obinutuzumab first on cycle 1, day 1 and day 2, cycle 1, day 8, and cycle 1, day 15. What this does is allows for significant tumor debulking prior to the initiation of venetoclax, which can often lead to a downgrade in tumor lysis syndrome risk. So one thing that I do, in addition to monitoring labs, for patients receiving obinutuzumab is I actually don't scan them at the start of the obinutuzumab. I scan them between cycle 1, day 15, and cycle 1, day 21. What this does is that it may decrease lymph node size and let patients avoid a hospitalization for high-risk tumor lysis syndrome. For the addition of obinutuzumab, I also give prednisone before obinutuzumab, which usually will help minimize infusion reactions, which I know that we all dread when starting the obinutuzumab. Usually 3 days of prednisone prior to the obinutuzumab does the trick in alleviating this side effect. After I get patients through the 2 months of hectic weekly visits with me for the venetoclax plus obinutuzumab, the main 2 side effects that I observe for patients on this regimen include diarrhea and neutropenia. Now, in terms of diarrhea, I've only had 1 patient who had to stop the venetoclax because they could not tolerate it. All of the patients really got away with taking loperamide, and some of my patients did only just need to take 1 dose of loperamide in the morning to alleviate their diarrhea. In terms of neutropenia, I want to go back to what I said earlier and say that once again, if we think that neutropenia is due to the underlying CLL involving the bone marrow, I will continue the venetoclax and just give those patients growth factor support. Now, if the neutropenia is secondary to the venetoclax because they don't have too heavily involvement of the CLL in the bone marrow, that's where we consider giving the growth factor support along with potentially dose reducing the venetoclax or giving a dose hold, and I follow the package insert. But in general, for patients who have CLL involving the marrow, and I think the cytopenia is related to the CLL as opposed to the drug, I do continue the venetoclax and I treat them with the growth factor support because ultimately the only thing that's going to improve that cytopenia is if we clear the patient's disease. So I think this is a key take-home point here and something that we should be thinking about for the future. There are some really interesting results that I like to highlight to patients that was presented at our most recent ASH meeting. These results looked at patient-reported outcomes for patients treated with time-limited therapy. The first one was an outcome report from the Gaia study that looked at venetoclax regimens versus chemoimmunotherapy and showed that patients' reported outcomes improved and were maintained even after time-limited therapy was completed, especially with the fatigue. Not surprisingly, while the venetoclax regimens were being given, patients did struggle with nausea, vomiting, and diarrhea. In the GLOW study, the ibrutinib plus venetoclax study, there also was a sustained and continued improvement after completion of time-limited therapy. So normally when I'm talking to patients about therapy, what to expect, side effects to expect, normally I say something like this. I tell them that usually when they start therapy, their symptoms will improve. They will improve over the course of therapy, but they may not improve to a baseline, meaning they may not ever feel 100% again prior to starting therapy. But if they're getting time-limited therapy, they get to stop therapy, which oftentimes will improve the side effects that they're experiencing. And based on this data, they will get back to somewhat of a baseline where they're feeling well without having the toxicities from therapy, which patients do like to hear. Let's talk about when to change therapies. There are 2 scenarios about when therapies need to be changed. For one, if we're on a continuous BTK inhibitor, we are talking about progression of disease. And of course, there can be progression of disease when patients are finishing time-limited therapy as well. And I typically wait for the patient to once again meet International Workshop on CLL criteria or IWCLL criteria in order to initiate the next line of therapy. Sometimes for frailer patients, I might do this a little sooner. I just get a little nervous when patients' doubling time is getting shorter and they start to have symptoms, but they're not interfering with their daily life. So oftentimes I might, for older patients, start therapy a little bit earlier than the classic IWCLL criteria for treatment. In terms of toxicity, oftentimes if I have to stop a drug for toxicity, like a continuous BTK inhibitors, I usually don't start therapy right away. Oftentimes, patients can wait a number of years before they start therapy again, especially if they had their disease very well controlled on the continuous BTK inhibitor. And so another thing, if some patients who have to stop therapy, they don't have disease control, I will often consider switching to another covalent BTK inhibitor, which may alleviate the toxicity that led to the dose hold and dose stopping. Additionally, if someone is progressing on continuous BTK inhibitor, I also will overlap the continuous BTK inhibitor with venetoclax until they get to the normal dose of 400 milligrams. The reason why I do this is that patients who are progressing on a continuous BTK inhibitor, if we abruptly stop, sometimes they can have a flare phenomenon where their disease gets out of control. So I like to overlap the BTKI with the venetoclax until we get to the standard dose. In terms of optimizing care for patients with CLL, I really lean on my team. I lean on my nurse practitioners and my nurses and pharmacists to be in touch with patients. We lean on our social workers to make sure that they provide support to our patients. I advise my patients to call in as often and as needed. We also will utilize the pharmacy to ensure compliance with our oral medications. And I also refer my patients to various support groups through the LLS, the CLL Society, and the LRF. And I find that my patients really do like these support groups and the media that is on these various websites, and they can usually link with somebody else with their disease in order to get the support they need. I'd like to take a moment to talk about a few of the services offered for free to both patients and healthcare providers by the Leukemia and Lymphoma Society. Through their Clinical Trial Support Center, clinical trial nurse navigators, especially trained in hematology and oncology, are available by phone, live chat, and email to support patients by providing user-friendly information and personalized help in finding appropriate clinical trials. These navigators assist patients and family members throughout the clinical trial process and provide information for patients to bring back to their healthcare teams. Healthcare providers can complete CTSC referral forms for their patients as well. See the web link on the screen for more information. The goal is not to enroll every patient into a trial, but rather to increase opportunities for participation by facilitating informed decision-making and minimizing barriers for the patient and their healthcare team. LLS has a team of information specialists who are highly trained oncology social workers and nurses who can give patients one-to-one support with accurate, up-to-date information about their disease, as well as treatment and information about financial and other supports. Patients and caregivers can contact them directly, or providers can complete a referral form. They can also help providers access and order free printed copies of LLS booklets on CLL and other cancers to give to patients. These services are available in many languages. LLS also offers free CME and CE continuing education opportunities for healthcare providers, as well as podcasts to offer updates on disease, treatment, and patient care. We hope you will leverage these supports and consider these specialists as an extension of your healthcare team. I have certainly utilized LLS in the past, specifically for their financial support, which I find patients to find very, very useful. So I want to take a second and talk about some hot off the press data. This is from the ASH 2024 conference. So first off, we discussed this in the first video, the Amplify study, which showed time-limited regimens with all oral options, acalabrutinib plus venetoclax, with or without obinutuzumab, improved progression-free survival versus chemoimmunotherapy. This data was also recently published in the New England Journal of Medicine, and we hope that the combination of acalabrutinib plus venetoclax with or without obinutuzumab will be approved for frontline treatment of CLL in the near future. There was also the Bruin CLL 321 study that compared pirtobrutinib versus investigator's choice, idelalisib rituximab or BR in relapsed refractory CLL. What's interesting about this study is that pirtobrutinib did lead to an improvement of PFS, and we may also see a change in the package label for pirtobrutinib, where it's allowed after only one prior line of therapy as opposed to two. Additionally, we have the Transcend 004 update. This was mentioned also in video 1, where ibrutinib plus liso-cel led to an improvement of overall response rate and complete response rate, practically doubled compared to what we saw historically with liso-cel alone in relapsed refractory CLL, justifying the use of the combination of BTK inhibitors with CAR T cell therapy for patients with relapsed refractory CLL. Really exciting. Two other things that we saw presented at ASH 2024, which may lead to approvals of novel exciting therapies in the future, include two BTK degraders. BTK degraders target BTK slightly differently than the covalent and non-covalent BTK inhibitors in that they lead to direct BTK degradation. So we're no longer inhibiting BTK, we are degrading it from functioning. This showed promising results for relapsed refractory CLL. Finally, we're going to have potentially bispecific antibodies for patients with CLL. These have now been approved for patients with other B-cell lymphomas, and we saw exciting data of epcoritamab, one of the anti-CD20 bispecific antibodies, specifically alleviating difficulties with cytokine release syndrome, which was previously a problem with CLL. So hopefully we'll have new approvals for some of these new medications for CLL in the near future. I want to end by talking about some key points and takeaways. For one, for toxicities, always consider a dose hold or dose reduction, and these remain important strategies. If someone has a permanent hold, there really is no rush to start the next therapy, especially if their disease is under control. Oftentimes, patients can have years of time before they require therapy per IWCLL criteria. In terms of progression, we can consider retreatment with time-limited options such as venetoclax regimens. And I oftentimes will overlap the BTKI if someone's on it and progressing with venetoclax as the next line to avoid tumor flare. In terms of the future, CLL clinical trials continue to be the utmost importance. I encourage you guys to reach out to colleagues who have clinical trials available. We don't know how we should treat CLL in the future without enrolling patients to trials, so it remains incredibly important. New combinations of targeted therapies are likely to be improved in the future, specifically acalabrutinib plus venetoclax with or without obinutuzumab. We'll also have new treatment strategies in the future. These may include bispecific therapies, chimeric antigen receptor T-cell therapies such as lysocell and others, as well as BTK degraders. So there are exciting options that are coming down the pipeline that may improve efficacy and be safer than what we currently have. So I want to end this by saying thank you for joining us for this last presentation of this 3-part series. Thank you.